Dear Chair, dear audience, it's a pleasure to present the progress of my PhD studies, the title of which is Investigating the Effectiveness of Arterial and Venous Endovascular Procedures. My name is Dávid Laczkó. I'm a first-year radiology resident and a second-year PhD student at the Department of Interventional Radiology at Semmelweis University. My vision is to eliminate the consequences of vascular diseases by making endovascular procedures more available and widespread. And in order to achieve this, my mission is to provide clinicians with up-to-date knowledge to help them choose the most suitable procedures. In order to achieve this, we started two specific projects that I will introduce today. Starting with the first one, where we investigated the effectiveness and safety of different embolic agents in bronchial artery embolization. We know that severe and recurrent hemoptysis is a life-threatening emergency with a mortality rate of up to 70 to 80%. We also know that bronchial circulation causes 90% of these cases, either due to inflammatory or malignant lung diseases. Possible treatments include conservative treatment, which lacks long-term effectiveness, surgical treatment, which has a high perioperative mortality, and the gold standard, the endovascular treatment. Now, the endovascular treatment can be done by using three main types of embolic agents. First, particle agents, including polyvinyl alcohol and microsphere. Second, liquid agent, also known as N-butyl cyanurate. And as a third agent, coils can be possibly used, but they can prevent further reintervention, so they are only used in addition to the two previous types of agents. However, there's no consensus on a gold standard agent at this point. So raise the questions if are particle and liquid embolic agents effective and safe in bronchial artery embolization for hemoptysis? We investigated patients with hemoptysis either treated with particle agents or liquid agents, and our primary outcome was the 1-year hemoptysis recurrence rate. Secondary outcomes were technical success, clinical success, pre-procedure and 1-year mortality, and the complication rates. And our hypothesis was that particle and liquid embolizing agents are both effective and safe in bronchial artery embolization. And our clinical implication was finding a standard of care for hemoptysis. Here you can see my search key. The first domain refers to the treatment, and the second domain refers to the hemoptysis. We've conducted a search in 3 databases. Originally, we find over 5,500 articles, and in the end, we managed to extract data from 59 articles. The first outcome that I would like to present is the clinical success rate. We talk about clinical success if after the embolization, the hemoptysis completely stops or at least substantially reduces in the first 24 hours. And this reflects the immediate effectiveness of the embolic agent. All of these studies were retrospective observational studies, and the results are in proportions ranging from 0 to 1, 0 meaning that none of the patients, 1 meaning that all of the patients had a clinically successful procedure. In the liquid group, you can see that the pooled effect size was 0.95, meaning that 95 patients out of 100 patients experienced a clinically successful procedure. Here you can see the same outcome for the particle group. Again, all of these were retrospective observational studies, and the pooled effect size was 0.95 here as well. But we can see a few outliers in this category, and this can be possibly explained by the fact that these articles investigated lung cancer patients. And you could also see that there is neither a clinical nor statistical difference between the two agents. Here you can see the 12-month recurrence rate. This reflects the long-term effectiveness of an embolic agent. Again, all of these studies were retrospective observational studies. Results are in proportions. However, this time 0 means that none of the patients experience recurrence, and 1 means that all of the patients experience recurrence. The pooled effect size for the liquid group was 0.14, and again, here we can see an outlier, which also investigated only lung cancer patients. In the particle group, the pooled effect size was 0.17, and we could also find a few outliers here as well. These also investigated only lung cancer patients, and we could also see that there was neither a clinical nor statistical difference between the particle and liquid agents. After seeing these outliers, we performed a subgroup analysis comparing the clinical success in the malignant and non-malignant group. Here you can see that the pooled effect size for the malignant group was 0.74, and for the non-malignant group it was 0.97, which was both a clinically and statistically significant difference. We also assessed the 12-month recurrence rates in these both groups, and in the malignant group we could see a recurrence rate of 0.66, and a recurrence rate of 0.11 in the non-malignant group, which again was both a clinically and statistically significant difference. To better visualize these results, here you can see the different recurrence rates at different follow-up times between the two groups. And as you can see, at the 12-month period, there was a significant difference between these two subgroups. Our study has a few strengths, mainly that a large number of studies were involved and we got a definitive answer to our clinical question. However, we were limited by the fact that only retrospective observational studies were available and the populations were quite heterogeneous. Our conclusion is that both particle and liquid embolic agents are effective and safe in bronchial artery embolization, and our implication for practice and research is that there seems to be no risk associated with using either of these agents, and researchers should be free to study this agent in a randomized controlled trial setting. We just submitted this article this morning into the Radiology Journal, which is a D1 journal. I would like to introduce you to my second project as well, where we are comparing the effectiveness and safety of single and dual antiplatelet therapy in patients undergoing endovascular intervention with intermittent claudication, and this will be a randomized controlled trial. We know that peripheral artery disease affects more than 110 million patients worldwide. We also know that due to this disease, over 50,000 patients undergo major amputation, costing up to $380 billion annually in the US alone. We also know that this is a progressive disease. Here you can see the stages of the peripheral artery disease. Symptoms can range from being asymptomatic to having intermittent claudication, and in later stages there's a rest pain, and in the end there's a necrosis. In this iceberg, you can see the distribution of these patients with the different stages and symptoms of the disease. And it has been proven that stage 3 or 4, which is the rest pain and the gangrene patients, they have a 1-year mortality of 20%. We can also see that a large part of the symptomatic iceberg is the patients presenting with intermittent claudication, and it is known that 30% of these patients will progress into the further stages at one point. So we know that in this population, an effective treatment and the post-procedural prevention is crucial. What this means right now in practice is the endovascular angioplasty with either using or not using a stent and antiplatelet therapy. However, here's a gap in our knowledge. We know that lifelong single antiplatelet therapy is always indicated, but the indication of a dual antiplatelet therapy is quite controversial, to say the least, and if it's indicated, then the duration is even more controversial. Here you can see a part of the 2024 European vascular surgery guideline, which gives a low level of recommendation with a low level of evidence that it should be administered for at least 1 month up to 6 months. However, there are no RCTs that compare these two therapies, so our aim was to conduct an RCT where we actually compare the effectiveness and safety of the single and dual antiplatelet therapy. Our research question is there a difference in the post-procedural clinical progression between the single and dual antiplatelet therapy in patients undergoing vascular endovascular treatment presenting with intermittent claudication? And our clinical implication would be to introducing an evidence-based standard of care for intermittent claudication patients. Here you can see a part of our eligibility criteria. We are primarily investigating patients under the age of 18 presenting with stage 2 peripheral artery disease with a stenosis confirmed by a CT or MR angiography. We are excluding patients with resting pain, gangrene, known conditions that require anticoagulation, or they are already on dual antiplatelet therapy. We have 2 arms. One of the arm will receive aspirin combined with clopidogrel daily for 12 months. The other arm will only receive aspirin combined with placebo for 12 months. And our primary outcomes would be the change in pain-free walking distance measured at 3, 6, and 12 months, or possibly the stenosis progression rate measured by ultrasound at these follow-up times. Secondary outcomes would be the rate of bleeding complications, change in the ankle brachial index, change in the stage of the peripheral artery disease, and the number of reinterventions needed. So in summary, we have these two projects going on. We submitted the first one, and we plan on submitting the protocol of a second study this September. And I would like to end my presentation with a quote from W.C. Fields: "If at first you don't succeed, try, try, try again." Thank you for your attention.
Thank you so much, David. My question is about trying, trying, and trying again. So, about your first project with the hemothesis. For malignant patients, the recurrence rate was actually quite high, yes. Around 0.6 if I remember correctly.
0.66 at 1 year.
And when you experience a recurrence of hemothesis, do you go back to yes. particle and liquid agents, or do you escalate the therapy into a surgical procedure? And the follow-up would be, what do you think? Should we try embolizing agents one more time, or should we directly go to a surgical solution?
To my knowledge, the first line of treatment is actually going back and re-embolizing the arteries. The problem with the surgical treatment, it has a high perioperative mortality. And if you are removing part of the lung of the patient that already has a compromised lung function, then it would further progress the disorientation of the lung function, so it would probably lead to the death of these patients sooner or later. With embolization, we don't really change the lung capacity and the other lung functions, so that's why it's the first line of treatment, even if an intervention is needed.
In the non-malignant subgroup, which are the most frequent diseases?
Usually pneumonia, bronchiectasis, cystic fibrosis is a very common in the younger population. And we actually wanted to do a subgroup analysis in the cystic fibrosis group because in our clinical experience, they have a high recurrence rate. But unfortunately, there wasn't enough available data to actually do a subgroup analysis of this subpopulation.
First of all, I don't know if the others know, but in addition, being a resident and a PhD student, David is also an excellent senior methodological supervisor in the critical care group, so a special thanks to you. My question is, how enthusiastic are you with your first project? On a scale of 5.
In what sense? I mean...
Because you concluded in your implication for research that physicians should feel free to compare these drugs. Now, your second project is about completely something different. So you say, okay, feel free, but I'm not interested anymore. So this is why I asked, how enthusiastic are you?
Yes. I'm completely...
And if you are enthusiastic, because of course you are, how would you do a randomized controlled study? Which drugs would you compare?
Yeah, I'm enthusiastic, of course. There have been no RCTs in this topic. I think the main reason is that even though the liquid agents have a similar complication rates compared to the particle agents, they require much more experience. So with the liquid agent, you can be just as effective as with the particle agent, but you can do some much more serious complications. I didn't go into details, but this glue is actually mixed with lipiodol, and by changing the dilution ratio, you change the rate of polymerization. So it's possible to achieve a deeper vessel penetration, but it's also possible to over-dilute the glue, and then this embolizing agent will end up in the systemic circulation, and it can cause pretty much anything: stroke, mesenteric ischemia, limb ischemia. I think that's one of the reasons why there have been no RCTs, but at our center I think people have experience with the liquid agent, so it might be feasible to actually do an RCT.